We can start now.
Okay, so we can start now, Afiq?
Yes, we can start now.
Yeah, okay. So, good afternoon, everyone. Welcome to today's series about advanced care planning. I'm Dr. Loh. I'm your facilitator for today's session. Today, I'm very happy to introduce to you someone very special and unique, Dr. Lam Chi Long. Now, he is not only my colleague in UMMC, but why I say he's special and unique, as a palliative care physician, definitely he's caring, but he has more than caring. Chi Long is known to us in our team being someone very fair, someone always, to find out what are our needs as a team. And being also very fair is he's very kind. Kind in a way that not only to understand, but also helping to find solutions. For example, when he leads our team to find solutions for our team, to plan what we want to do as a team. So today about advanced care planning. So we are talking about, this is something important in palliative medicine. So without ado, won't waste time, we will let Chi Long start today's session.
Thanks very much, Ichin, for the very kind introduction, and thanks everyone for joining this session today. I'm going to talk about advanced care planning. It's a topic quite dear to us, I would say, as palliative medicine physicians. And I'm really going to go through a number of stories just to tell you how advanced care planning can be done and what the purpose of it is. It's not especially high-tech and detailed from a scientific literature perspective, but I will spend a little bit more time focusing on communication and how we can begin to talk to the people we look after. All right. So just to begin with, I'm just going to start with a quote by Atul Gawande. I hope you have read this book, or if you haven't read this book, I will highly recommend it, Being Mortal, Medicine and What Matters at the End. And in it, he said, "We've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being." Okay. So the outline of what I'm going to go through today is really cover briefly the concept of advanced care planning. I'm going to go through some examples of communication and conversations that I've previously had with patients, and maybe give you some tools and resources as a step forward that maybe you can begin to have these conversations with people in your own hospitals and maybe start formulating strategies, because whether you're a specialist, whether you're a medical officer, in time you will be the lead for the field in your place of practice. And maybe after that, we can think about, how you measure success in advanced care planning and how we can move forward in it. I will admit that advanced care planning does take time, and I know everyone is very busy in all the hospitals that you work at. And I don't think this is something to be done during your main ward rounds when you're trying to sort out business, when you're trying to stabilize ill patients, when you're trying to sort out discharges so that you can clear some bids. But maybe if you have some space and capacity in the afternoons, or maybe if other members of the team can take this on, it's about teamwork, and it's about sharing the work, and it's trying to provide better care for patients. All right. So I feel very strongly about telling stories. And Elliot Perlman, who's an Australian, and he wrote a book called The Street Sweeper. In it, he said this: "Wouldn't you want someone to tell your story? Ultimately, it's the best proof there is that we mattered. And what else is life from the time you were born but a struggle to matter, at least to someone?" So I think all our patients are struggling to matter. I think they all have stories to tell us. And I think all the people we meet on a day-to-day basis also teach us in a way to be better if we are open to listening, and if you're opening to trying to understand where they're coming from and how we may care for them better. So I'm going to start with a story. As I said, I'm going to be telling stories today. I met a lady with diabetes and hypertension and end-stage renal failure, which was on hemodialysis sometime last year, just before COVID began. She was in her late 60s. She was able to ambulate over short distances, but because of worsening peripheral vascular disease, she was finding it increasingly difficult, and she was getting more and more severe pain and rest pain over time. And she had seen our colleagues in the vascular clinic prior to that, and previous conversations did broach on the subject of amputation. But on the previous occasions when she's had that discussion, she said, no, I don't want amputation. And she wasn't suitable for any vascular bypass surgery. So unfortunately, she got admitted one day with hypotension and septicemia. And quite rightly, the team looking after her started her on antibiotics and inotropes. But because of her severe pain, they called us as the palliative care team to go and see her and see whether we could help. So when we went to see her, she was clearly quite delirious. She didn't really know where she was at. She was in quite severe distress, and she just kept shouting, "Sakit, sakit, sakit." And so, yeah, we had to do something rather than leave her like that. So in the first instance, because of end-stage renal failure, I put her on an infusion of fentanyl, tried titrating it. But as all of you know, one of the side effects of strong opioids is you may get some element of drowsiness. And on the background of someone who is already delirious, it was quite hard to find a balance, because the more we gave her, the more sleepy she became, and the more concerned her husband became. And the less we gave her, the more she started screaming and shouting because of her pain. And eventually the primary team looking after her decided that, said to the husband, your wife's like this now. We can't resolve this infection just with antibiotics. We need to cut off her leg. But prior to this, she had always said she didn't want her leg cut off. But I think the husband, in the position he was, no doubt being very caring for his wife, eventually decided that, okay, go ahead and cut off the leg, because if that can resolve this problem, then I think that's okay. So they went ahead with the operation. She came back with a below-knee amputation. She was still delirious and confused, I'm afraid to say. And subsequently, her other leg also became more ischemic. And the primary team then had a further discussion with the husband about taking off her other leg as well. And eventually, after further discussions, they decided, okay, let's amputate the other leg as well. So this lady ended up with one above knee amputation and one below knee amputation. And I remember seeing the husband after that and seeing the lady after that. And at moments, she was looking very distressed as to, where are my legs? Where are they gone? And this was in a lady who was still delirious, because the delirium hadn't really settled as well. And there was very little scope to rehabilitate her, because she was quite weak to begin with. And it always struck me over the course of that, how could we have done better for this lady? I mean, what did she want if she could actually tell us? And sadly, what happened after that is COVID came. And it was one of those processes where the hospitals were trying to empty their beds, anticipating a huge wave of COVID patients after that. And this lady got transferred to another hospital in the Klang Valley. And if any of you happen to look after her, I'd be interested to know what happened, but I never heard anything more again. The husband really was not able to look after her. She could not really move herself in the bed, and I couldn't anticipate or envisage how this lady could be taken to hemodialysis without someone physically having to carry her to whatever transport she had, or put her on a stretcher, take her there, bring her back, and that would be the remainder of her life. And I don't know how all of you feel in this circumstance, what we should have done or what we could have done. Suffice to say, she previously didn't want an amputation. Maybe she wasn't clear that she may have died without the amputation, and that was one of the justifications for proceeding. But could we have cared for her better? Could better decisions have been made in a multidisciplinary sense between the vascular team, the orthopedic team, rehabilitation, us, the nephrologists, to try and maybe guide or recommend treatment a little bit better, considering we had no idea what this lady wanted. So if I were to go through a strict definition of advanced care planning, this was a definition, an attempt at defining it by a consensus panel back in 2017. And they described advanced care planning as such. It's a process that supports adults at any stage or age of health, age or stage of health, in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. So advanced care planning, I guess in a nutshell, is really about respecting people's autonomy and respecting people's choice. Because if they can make decisions at a point of time when they are well, if they become unwell, we should still respect their choices because they're still very much the same person. And that can guide us as physicians looking after these people, how to tailor their treatments to their own values, their own goals, and their own preferences when they're less well. So the key components of advanced care planning are these. The first one is it's a voluntary process. I could go to someone and say to them, oh, Mr. So-and-so, I wonder whether I can talk to you about your illness. You know, what may happen in the future, what to expect. Is that something you want to talk about? And they can very well say no, in which case that's okay. I've given them the choice. But if they say yes, then we can start beginning to have a conversation with them. What could be foreseen, what would be their worries, what will be their, what we can try and explore what we need to know about them in order that we can look after them better, what they would prefer, how they would like to be looked after, who could make decisions on their behalf if they were less well, just as an examples. And it's a process. We don't just do it and it's done and it's the final article, because people change their mind over time. I mean, sometimes you may have a patient who with end-stage kidney failure who may say, no, I don't want dialysis. And when the crisis really happens and they're not ready and they say, I want dialysis, then it's okay to change their mind. There's nothing really wrong with that. This is about care. This is about respecting people. You can give them choices. If they change their mind, you can say, well, we can still go ahead with dialysis, but the other option is to just give you medications to try and reduce your breathlessness if it's fluid overload, reduce your distress in other way. If there are other ways, we can do it. So it's about giving people those choices and making it available, at least, so that they have some control over what they're going through in life when everything seems to be falling down around them. So it's voluntary, it's a process. You know patients over time, we have relationships with them, and we build that relationship, and we get to know them better as we look after them over a longitudinal period. The second thing about advanced care planning is that people need to have decision-making capacity. I'm not going to go into detail on that today. Suffice to say that, yeah, if someone needs to make a decision regarding their care, their future care, for example, they need to be of sound mind. They can't have any impairment of mind. They can't have any mental illness that may be affecting their decision-making related to that decision. So it's just important that we are satisfied by that. And by and large, we are supposed to assume people have capacity unless we have reason to believe otherwise. And we are meant to support that decision-making if they need assistance. So a few weeks ago, I had a man who had a laryngectomy. He had an emergency tracheostomy put in because he got stridor, and he spoke Chinese. And one of the things I always lament to Yichin is that, when people speak Chinese, I have such difficulty communicating with them. So he couldn't even verbalize. He was almost mouthing, and I couldn't even read what he was saying in English, let alone Mandarin. And thankfully, the next day, his family members were called in for family meeting, and they helped translate, which helped us understand where he came from, whether the decision to do the emergency tracheostomy was correct, how we could care for him better in the longer term. The next step is that there needs to be two-way information sharing. Patients rely on us as doctors, as the medical experts, to provide them information in order to guide their decisions. We know about illnesses, we know about pathophysiology, we know about problems and prognosis and things that may arise in the future, which they may have no inkling about unless they've come across such problems before. And on the other hand, they are the content experts of their own lives. They know themselves, they know who they are. They know what brings meaning to their lives. They know what's important to them and what they live for. And so through this exchange of information, we can hopefully have a better idea of what personal values people have, what their life goals are, and what preferences they may have on future medical care. And I'll share a little bit more about this in time when I kind of discuss a few other cases or examples. But we're trying to explore this so that we can treat people how they want to be treated and individualize care rather than treat everyone the same because their illnesses or problems may be the same. Everyone's different. We're all different. All of us like to eat different things. All of us have different hobbies. And it's very much the same for all the people we look after as well. So at the end of advanced care planning, hopefully you have some idea of their wishes, life goals, preferences. You may have an idea of things that they don't want. These are decisions to refuse treatment. And you may have identified someone who may be a proxy decision maker in the event the patient can't make decisions themselves. So those will be the typical outcomes that you may achieve at the end of these sorts of conversations. But as I said, they're not one-off. You can explore them over time if you can't finish it in one go or if the patient doesn't want to go there. So why do this? Because people lose mental capacity. In the example I gave earlier, I don't know how all of you feel. As I said, would you want to take off her leg or not? Do you think it's the right thing or wrong? She didn't want it done before, but she may not have been aware that she would have died as a result of it. And that may be justification in a medical emergency to proceed. And the husband certainly signed the consent form permitting the surgeons to proceed at the time. Mental capacity loss can be transient or permanent. In her case, it never really improved for as long as we were involved in her care. But sometimes if it's transient, maybe if you can delay the decision till it returns, then you can ask them again themselves. And it's helpful for crisis planning because when you have a crisis, everyone's emotional, everyone's rushing all over the place. No one really thinks very clearly or straight. And it's much better planning these sorts of things in the cold light of day when things are stable than when things are out of control. So we want to do this because we want to ensure that care is consistent and aligns with the patient's wishes and goals in people with serious illness and chronic illness. This is about the quality of care, caring how people want to be looked after. And just to echo this, the president and CEO of the Cedars-Sinai Health System in the US said this, that goal concordant care for the seriously ill is a matter of appropriateness, of doing the right thing, period. Providing care that is aligned with patients' goals and values improves efficiency. Okay. So the other thing I will add with ACPs is that yeah, I'll just go through another example here of a scenario, and maybe the really bright ones among you can make a diagnosis based on these T2 weighted MRI scans. Feel free to type in the chat. Suffice to say that when I first learned about ACPs, and this was back in, I think about 2006, the Mental Capacity Act in the UK was introduced in 2005. So we all learned about it and we thought, oh, wow, we can have decisions if patients to refuse treatment in advance. So very pandai, I went to go and talk to a patient who I thought was a really bright, educated, tertiary level educated guy who had this illness. And I asked him, yeah, would he like to have conversations about his future care? And he was like, yeah, okay, yeah, I don't mind. And I asked him about his illness and what he understood by it. And he had been quite well informed by the neurology team looking after him that this was a progressive illness that got worse over time. And he was likely to kind of meet his demise as a result of it. And so again, in my ignorance, and in a way, this is how we learn. I remember at one point asking him, you know, if you got worse and let's say you had an infection, do you think you'd want antibiotics for it? And he looked at me and he said, will they help? And I looked back at him and I said, yeah, they might help, you know, if you have an infection because antibiotics can treat infections. So he looked at me and again and said, why not? Then I was like, oh, Yeah, you have a point there. What am I actually trying to ask you? And something that I realized after that, and I think many of us probably fall into this trap as well. If you go to a patient and ask them, do you want resuscitation or not? And then they say, yes, I want. And then we've kind of dug a hole for ourselves unless we were really prepared to resuscitate them. So another thing that I would add is that and where I really fell flat there in my first efforts at trying to have advanced care planning discussions is that any decision in advanced care planning needs to be very contextual. Contextual in the sense that here was a man who was relatively well at that stage of time. Um, and I was asking him about infections, and he had no idea what it would mean, and he had no idea what he would be like at that time. He really wasn't able to have that conversation about, it's not because I didn't give him enough information, but he couldn't envisage that in 3 months' time or 6 months' time or 1 year's time, what he would be like. If he got an infection the next week and he decided that he didn't want antibiotics, was that going to jeopardize his care and treatment? The conversation I was trying to have with him was totally out of context. And in a way, that's one of the dangers when we all have conversations about CPR with patients. If you just go to a family member and say, you want CPR for your relative? Not, they'll be like, huh? Oh, yeah, do everything, doctor. Do everything you can to help. Because they don't really grasp what the situation is. And that's kind of a failure of communication on our part in trying to make it clear to patients and their family members where things are at, how things are. And I feel very strongly in these situations that as physicians, we need to provide a little bit more guidance, at least, about what to do. Because vast majority of these people are lay members of the public, and they may have medical kind of education or medical aware. They may have limited medical kind of awareness or insight about their problems. So we need to be able to provide the information to people in order that they can make these sorts of decisions. Otherwise, they're totally out of the blue. People don't even know where to start, and it's quite challenging in those circumstances. So I would quote William Osler here, who said that the good physician treats the disease, the great physician treats the patient who has the disease. And I will start with a disclaimer that I'm not great in any way. I think many of you are really fabulous physicians. Your medicine, your application of medicine is, I admire and look up to how bright and perceptive and sharp many people are. But on the other hand, you can always treat diseases and follow guidelines and follow latest protocols. And I have no doubt you're treating the disease properly. But how do you treat the patient who has the disease? How do you find out a little bit more about the patient in order that you know how problems could be tailored to the individual? As I initially started with Atul Gawande's quote, we're not really trying to prolong survival forever, and that's not primarily our aim. We want to try and restore some well-being in the people we look after, and that requires a little bit more exploration on our part as doctors. Okay, so I'm about 1/4 of the way. Yeah, okay. So I'm going to spend the next moments about having conversations with people. I must admit, when I was a medical student, I hated communication skills sessions because I was thinking, oh, what's the point of all this? We were just videoing one another and watching back the videos and feeling very awkward and uncomfortable looking at it. And I would also say that I really don't feel personally gifted with communication. You can ask my wife, she'll tell me that I'm terrible. And I feel I've had to work very hard. I've had to think very hard every time I want to say something, what to say. And sometimes it helps that while I'm thinking, I'm silent. And silent is a great facilitator for communication. But nevertheless, it's something that everyone can learn. And for many of you, you have to sit a com skill station in your MRCP paces, and you have to sit an MRCP, a com skill station in your MMed exams as well, if you are at that stage anyhow. So I think there is purpose, and it's hugely helpful being better or practicing communication alongside all the clinical things and the CPGs and the other things you're trying to learn, because this is a little bit more alongside the art of medicine as opposed to the science of medicine. Okay, so another story. This is really about a very young lady I met. She was in her 40s. She was a professional, single, quite successful in what she did in her professional career, but sadly was affected by a gynecological malignancy. And she'd been through, I think, 3 lines of chemotherapy prior to the time I met her. And I think she had just started another round of chemotherapy as well. She was brought to hospital very unwell because she was septicemic, febrile, hypotensive, quite unwell actually, tachycardic. And credit to the team admitting her again. They treated her kind of faultlessly in emergency. She ended up on antibiotics, fluids, needed inotropic support initially actually because her blood pressure was so low. And by the time I was asked to see her on the ward by her primary team, went in to say hello, and she had a sister with her. Very caring, no doubt very keen to see what this palliative care doctor had to say. And in our initial exchanges with her, her main problem was pain in her back. So our initial plan was just to start her on some analgesics. And then we said we'll see her again the following day. And I have to give credit to my colleague here, the specialist who was working with me at the time, because when the specialist went back the next day, this lady broke down in tears. And she said, "I wish I never woke up." And we were like, "What?" And she said, I wish I never woke up. She said, "I was feeling unwell at home, but I just decided to stay at home because I didn't want to come back to hospital. I just wanted to get worse and slip away and die." And she said to us that, "I know I'm not going to get any better. I've gone through 2 or 3 lines of chemotherapy already. My legs are swollen. I'm stuck in bed. I'm not going to be able to get back to returning to my job, which I love so much, and seeing the people who matter to me. I just wish I went." When I eventually woke up in the hospital bed, my family were around me. And they were all so happy, and they were cheering and welcoming me back. But in my heart, I cried because I just didn't want to be here. And she said that to us because her sister wasn't there. And we said, "Have you spoken to your family about this?" And she said, "No, I can't raise this with my family at all. Every time I talk to them about this, they scold me. They tell me I must be positive. They tell me I have to get better and think more positively because there are still things the doctors are able to do." So I must admit, I've talked about this case before in my faculty, and I'm very ashamed to say that when I asked all the audience at the time how many would treat this lady if she came back again with septicemia, and on one hand, more than half said they will still give her antibiotics and do everything the same again. But on one hand, I feel quite uncomfortable with that because she's kind of told us straight from her own mouth that she doesn't really want any more treatment and she just wanted to die, and she was ready to die. I accept maybe there are some things that we had to resolve with the family initially before to maybe try and smoothen that path, because if she comes back and they said, "No, we're not going to treat her," and they'll be like demanding and all sorts, we probably had some work to do in having these conversations with them. But yeah, in our faculty, at least more than half of the people who were present on that day wanted to give her antibiotics still and treat her exactly the same way. I certainly wouldn't, because here has someone said directly in no uncertain terms that they don't want treatment anymore, and they were ready to go. And I strongly believe in respecting people's choices, and we should be supports and we should be advocates for the patients at the very same time. If you have concerns about whether this is legal or illegal in Malaysia, you are quite right to ask that. And in Malaysia, at least, we don't have any laws pertaining to these sorts of situations, advanced directives and living wills. But we have some guidelines from the MMC from back in 2016 that says this medical practitioner should refrain from providing treatment or performing any procedure where there is an unequivocal written directive by the patient that such treatment or procedure procedure is not provided in the circumstances to which they apply now. The only reasons why you may want to ignore the directive is that if it's illegal, if it's vague, it's not applicable in the circumstances, they weren't coerced and they were competent at creation, and it was a valid and recent directive rather than something like 5-10 years old. Thankfully, the MMC guidelines give us some wiggle room that if the medical practitioners can still treat patients according to the professional judgment of what the patient's best interest is until legal advice can be obtained. But yeah, I think even accessing legal advice or direction can be quite a challenge here at times as well. So you can respect people's wishes. And I certainly, having had that conversation, my colleague having had that conversation with this lady, did want to respect her wish. So we had a meeting after that with her primary team, and the boss was aware of it actually, much to my amazement, and that's credit to her. But on the other hand, also we had a conversation with the rest of the family. And after that, yeah, her sister stayed the night with her. They had some quiet time together between two sisters just to share in what was happening. And she died about less than 2 weeks later, I would say, from that admission to hospital. The sepsis had resolved, but she was quite weak from advanced cancer again. Just another example. This one was another patient I came across. She had cancer, lung cancer. She'd been admitted to our oncology ward for about a month as a result of sepsis. And as a result of the sepsis as well, she developed acute kidney injury, which was worsening sadly. We got asked to see the patient just to have conversations about further care and community support through a hospice. And the nephrologists were also seeing the lady because they wanted to discuss dialysis. So I initially went to the ward. I passed the nephrologist as they were leaving, and they told me that they offered her dialysis, and she was agreeable to having dialysis for her kidney injury. And I must admit, when I went to the room for the first time, it looked a bit like this, albeit with a woman in the bed. But there was this huge crowd of family members, sons, daughters, aunts, uncles of Indian descent. This was pre-COVID. Some of them very stocky and burly. And I'm always quite wary walking into rooms like this, like wondering what the family are going to think when I open my mouth and say something. But anyway, I introduced myself and said I'm one of the doctors, and a colleague of mine, Dr. David Capel, was there as well. And I asked her how she was, and she said she was quite tired, stuck in her bed. And I asked her, how were things before? And this lady was the matriarch of the house. She really ruled the roost. Everyone around the bed kind of stood and listened and followed her every word. And she was a really house-proud woman who liked looking after the house, walking around, cleaning, tidying, cooking, looking after everyone. And in this instance now, she couldn't look after anyone, and everyone was having to look after her. And I asked her how long she'd been in hospital, and she said about a month. And I said, you must miss home very much. And she said, yeah, I really, really, really want to go home. And so I said, I heard the nephrologist has just been. What did they say? And she said, oh, they've said I had kidney failure and I needed some, and they offered to give me dialysis to try and make the kidney failure better. And I said to her, what are you hoping for? And she said, she hopes she can go back home and look after the house and walk and do the things that she could do before. I did explore things a little bit more, and it did turn out that even prior to admission and the weeks leading up to admission, she was already becoming weaker and not really able to walk anymore. And so I said to her that, do you think the dialysis is going to help you do that? And she looked at me, and the whole family looked at me, and they said, and she said, why is it not, doctor? And I said to her that, well, I think on one hand, this difficulty walking came on even before your kidney problems started. And if we fix your kidney problems, I'm not really sure that that's going to get you back on your feet again. I'm a little bit more worried that the reason why you can't walk is more because your underlying cancer is getting worse instead. And they all looked at me and they said, but we have to try, right? We can't just do nothing. And yeah, I chickened out here. I said, well, yeah, you're right. If you want to try, I really don't want to stop you doing that. Try it once, try it twice, try it 3 times. By then, your kidney function should be better. And you see how you feel. Because if we keep doing this dialysis to you, we may be keeping you in hospital, or even when you go home, you may be having to go to a dialysis center 3 times a week. And if you can't walk, it may not be very easy to get there. And even undergoing the whole process of dialysis, maybe after a time or two, you may be able to see what it's like and see whether that's something you feel comfortable going through or not. So that one of the sons said, yeah, we want to do that. And I said, okay, that's fine. If you want to do that, I think I just want to give you the options so that you know where things are at and what we think as doctors, because we want to try and help support your choices and do what you want as best possible. And what I would suggest also, why don't you try it a few times and you see whether it's okay or not for you. If you do it and you feel it's not okay, that's fine. You can stop your dialysis and go home. If that's what you want to do, if you don't feel it's doing the things that you want it to do for you, then I think that's perfectly reasonable. And so we kind of left it at that. I heard she went home after 2 sessions of dialysis. She never came back to a hospital again. She may have gone to a private hospital to get further treatment. I don't know, but I have come across some people like that before. But I like to think again in this situation that in understanding the lady, in knowing what she was after, in recognizing what her goals were, we could at least guide certain decisions by knowing her preferences and wishes. And in a way, that's what I would kind of encourage everyone as MOs, as physicians, partially because you will not have enough palliative care doctors in this country to have these conversations for you. In a way, everyone needs to be able to do this. And it's something that we feel strongly about. And I know my colleagues in Selayang, in Queen Elizabeth Hospital, in Ipoh, have all been trying to do their own things in some way, trying to introduce these ideas of advanced care planning to the medical teams there, so that all teams can start having these conversations and maybe adjusting care to people's needs. So the key skills that you really need in these conversations, the first one is presence, because I don't think that First Lady would have shared how she really felt with us if we were just there to sort out the business and leave. The fact that someone was there genuinely wanting to know and genuinely interested with her, I think was a first step towards her opening up and sharing her heart with us. The second thing, which again, my colleagues will say in your MRCP PACES exam, key skill is listening. And this is just not listening to give someone an answer. This is listening to try and understand where they're coming from, to clarify what they're thinking, to know them better and who they are. And this is driven by curiosity, or as my colleague Yijin will say, it's being very kepo and trying to find out more about people. Yeah, how can we know people better? What's important to them? And we need empathy as well. And these things, I can talk about them like this, but I would strongly recommend, if there are opportunities to practice this, if there are workshops to attend, take advantage of them, because you kind of need to see how to do it before you have a sense of how it may be done. Something I find quite helpful as well that Yichin first introduced to me, I would say, was having a clear goal. And sometimes, rather than setting a goal as you want CPR or not, you want ventilation or not, you want NIV or not, you want inotrope or not, you want antibiotic or not, rather than setting a goal like that, it's sometimes more helpful to set a goal from a point of view of, do people want cures? But in medicine, I would say it's not very, very common. And more often than not, maybe our goals may shift between prolonging life in people, if the life is still meaningful and of adequate quality to the patient, or is it comfort that they are after? So in the last two patients that I talked about, I think they both wanted comfort in a way, but they wanted comfort in a slightly different sense. One was hoping that maybe the dialysis would get her a bit stronger, and that was, yeah, I guess that partially life prolongation as well. But if it wasn't really going to achieve that meaningful life for her, then she opted for comfort and she decided to stop dialysis and go home. I added cost here as well, because sometimes in making these decisions, there is a cost that has to be borne by the patient too. So as an example, if I want life prolongation, I'm going to have to put up with the IV lines, the antibiotics, the repeated blood tests, the potential NIV or ventilation, and the family have to put up with the cost as well. And again, something that I've learned in time is that, yeah, you can't just say put them on a ventilator and then free yourself of all responsibility. If you want someone to, in a way, I think my colleague Ichin, and maybe she can share a bit more later as well, is that if people want to be put on NIV as well, then they have to be prepared to care for the patient. You can't just say put on NIV and leave in hospital. You are as much a partner in this care as we are in trying to support your family member. If you don't want to help with the supporting at home and the discharge and the learning how to care, etc., then it may not be that viable an option to proceed to such levels of interventions. Okay, so just some tips, and I must admit some are a little bit more Western, but maybe you may need to Malaysianize that. And I know one of my colleagues, one of the specialist trainees, is trying to translate some things that I'll share in time. But these are some questions that Atul Gawande, who's a surgeon, was told by a palliative care doctor in the US as to how you can start. So she told him 5 questions to ask all his patients if they were faced in these dilemmas that they may deteriorate from serious illness. And these are the questions. What is your understanding of where you are of your illness? I think everyone asks this generally, or more often than not, I think the Malaysian way of asking this that maybe is a little bit more blunt is, the doctor told you what about your illness, or told you what did the doctor say? But you're really trying to find out what they had been told before and what their understanding is. The second thing he recommends is, what are your fears or worries about the future? And these questions are just starting points, because what people say can be explored further. Oh, I'm just worried about getting worse. Yeah, what is it about getting worse that worries you? Oh, I'm just worried I'll be stuck in bed and won't be able to walk anymore. And what would that mean to you? What would that mean? Oh, I'll have to, my kids will have to look after me, or I may get sent to the nursing home. Is there anything else? Just explore it. Use it as a starting point, a springboard from where you can find out more about what people's concerns are. Yeah. And if things were like that, what would you like then, or what would you hope for? Just wish I could go there then. I think that's really helpful to start with, because maybe, just maybe, as a team looking after this patient, if things ever reach that point, if they could still talk, you can ask them. But if they can't talk anymore, you've heard it straight from the patient. What do they want? How they feel about these situations? And it's good as well if these conversations can then be held with family members, so that they are kind of party to it and hear it straight from their loved one as well. But there will be conflicts. I don't deny that. Now, what are your goals or priorities? I sometimes ask people, yeah, what else do you want to do in life? Or you're 78 already. What other ambitions have you got at this point of time? Try and find out more about people. Sometimes they say, okay, life fulfilled already, ready to go. That's okay. That's helpful to know. And if it's time to go, where would you like to be if that was the case? And they may say, I want to be at home, or I may want to be in hospital. The fourth question is a little bit hard to ask sometimes, because what outcomes are unacceptable to you? What are you willing to sacrifice and not? And what this relates to are things like, yeah, if you treat me and I'm kind of bedbound and blind and something like that, that's really not an outcome, severe side effects, etc. Willing to sacrifice is almost what they're willing to go through, blood tests, invasive procedures, things like that. Sometimes if they've been through it before, you can relate to that. Oh, you were in ICU previously. What was that like? What do you remember from that, being on the ventilator, for example? And see what people think. And how would you feel about going back on it again if you were really ill? Would that be right for you? And some of them may say yes, some of them may say no. But again, this is about care planning, and this is about tailoring things for people so that when they're less well and they cannot speak for themselves, you know what to do. You can ask someone, if things were really bad, what would be really important to you? And as an example, just phrases that maybe you can begin some of these conversations with. What would a good day look like? If you wake up in the morning, what you really look forward to in the day that you're able to do. And if you can't do that anymore, then how? Just ways of exploring it, I would say. I quite recommend this website. It's called Vital Talk, vitaltalk.org. Feel free to look it up. It's got some quick guides how to have communication. So like I said, one of our specialists is trying to translate some elements of this into Malay just to see whether it would work, or trying to Malaysianize it at least into Malaysian English initially to see whether, and then it's something to try and test on patients and see whether it would work or not. So just as an example, this is a conversation about transitions on goals of care. And it's based on something called the Remap tool. So the first thing, step one, reframe why the status quo isn't working. So you've given your family members antibiotics for so many weeks now, and we've upgraded it 2 times already, and they don't seem to be getting any better. I think bearing this in mind, it may be a good time to talk about what to do now. So that's how you kind of introduce the idea that we really need to have a conversation about what's happening next. And if they are emotional, like, you've tried so hard and you mean they're still not improving, I can't lose him, then it tells you what to say. It's hard to deal with all this. I can see that you're really concerned about your family member. Just as an example, can you tell me about what you're really worried about? You don't have to use all of them, but they're just pointers or tips how you may begin to have these conversations if you've never had comm skills exposure or experience before. The third thing is trying to map the future, and giving these situations what's most important to you, and are there things that you really want to do, and what concerns may you have. So it's just trying to see how the patient sees out the future, and then aligning with the patient's values. As I listen to you, it sounds like the most important things are being at home, having your children around you and your grandchildren, being able to walk and talk and see them. It sounds like most of our treatments just need to be trying to our best to keep you in that way, and you really don't want things, if they were worse than that, it really wouldn't be acceptable to you. So that's trying to align with the patient's values. And then as the next step, you plan your medical treatments. Here's what I think you can do. Can I recommend that we do this? So instead of ending up in a situation where we are asking people, you want CPR or not? I don't, because if you can establish that someone's goal is comfort, I think that's quite easy already. Personally, I would say that if our goal is comfort, we just need to be focusing on the things that will add to your comfort. Doing anything heroic, exciting may not be so aligned with your comfort anymore, and we won't take measures along those lines. And I would tell people in kind of no uncertain terms that it won't be helpful. Okay, and there are just a few other kind of questions may come your way, but this is just an example of a one-page guide. I was very lucky that my colleague from QE once asked me to go and talk to them about to help with one of the advanced care planning workshops, and they came up with a kind of idea guide as well, what to do in each steps. I'm sorry, it's very detailed, but if you really want to copy, I'm imagining that the QE palliative care unit led by Dr. Ng Wan Jun will be happy, and I'm sure the Selayang unit as well, who have a template and of questions, may find it very helpful as well, but I don't have one on hand to share with you all now. So only have 4 slides left. Eric Cassell, who sadly died a few months ago, but he's almost like the godfather of suffering. He said this: the relief of suffering and the cure of disease must be seen as twin obligations of a medical profession that is truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. So I think sometimes I think the worst things we can do is healthcare-induced suffering. If it's for a gain and the gain definitely outweighs the benefit, then it's worthwhile. But if the gain is small or you're not achieving any gain, maybe it's time we need to revisit what we're doing. Okay, so just two very quick things on moving forward. The first one is, how do you know your advanced care planning is successful? So from a Delphi panel of 50 experts, they described outcome constructs. If care received by the patient is consistent with their goals, then I think that's the best outcome you can achieve. This panel thought deciding a surrogate's really important, documenting the surrogate's really important, and discussing values and preferences with the surrogate is very important. I would have thought discussing things with a patient is more important than the surrogate, but yeah, so says the 50 experts who were involved in this study. But the main thing I want to emphasize from this is that advanced care planning does not succeed with an individual. Advanced care planning succeeds because the system in a hospital recognizes it's important and tries to build processes in place to kind of enable it to work. If I have a care plan with a patient, but they come in through emergency don't know what we talked about, they will do what emergency does. And again, huge respect to them for what they do at the front line. But it's a system, like I said, that's important, and emergencies somehow need to be linked into the system. The community needs to be linked into the system such that if someone is worsening at home, and we've had discussions before, how can that be kind of conveyed to the community as well? Or if there's a crisis and they come in, how can the community transfer the information to emergency such that everyone at all levels feels that this is important? You cannot fix a downstream problem at the end of the problem. We couldn't fix that first lady's gangrenous leg with peripheral vascular disease at that point of time. We had to kind of make these decisions much earlier on in the course of illness. And the vast majority of deaths of patients in hospital are predictable and foreseeable. So I will finish with this. If at first you don't succeed, try again. I've made many mistakes in my time. I continue to make mistakes now, but I have to think back on my mistakes and figure out how I can improve as well. And if you really don't know what to say, or if you have conversations with people and you're stuck and you don't know how to move forward, talk to a friend, talk to someone else. I'm happy to listen as well. I'm not saying I got all the answers, but how else can we advance these conversations? We need to practice, not till we get it right, but practice until we can't get it wrong. Okay, so I'll just finish, and I'm sorry, gosh, I only had 28 slides, but I've been talking so much. So take home messages. I feel strongly that failing to plan is planning to fail, and we'll end up with more and more people like this being treated in a way that you feel very, I feel very uncomfortable with, because I'm not sure whether they're truly aligned with what patients want or not. Have these conversations with people and try to align the care that you provide to the hopes and goals and priorities of the people you look after. Okay, I'm going to stop there. I'm so sorry I've gone over time badly, but if there are any other questions, I'll be happy to go through them.
Yeah. Okay, thank you very much, Chilong, for the very practical yet very comprehensive discussion about advanced care planning. So we will open the questions to the group. Anyone has any questions, you can open up your mic, unmute, or you can write in the chat box.
You need to ask questions, because if you don't ask questions, then Ichin will ask me very difficult questions.
Okay, I will try to do some summary to stimulate you to ask some questions. So point number one is, I think whatever Chilong shared with us is going to be relevant to everyone here, each of you attending here. Why? You don't need to do palliative care to have this conversation, but you need this conversation to have become a good doctor. You need this conversation to do a good job. And if you can do that, you'll be a good, kind doctor, and therefore you will have a job. So this is what I will challenge you. Esther, yes, you put up your hand. Please ask question. Unmute yourself, Esther. Or you just agree? Agree. Okay, fine. So I'll continue. I think the other thing Chilong said from the very beginning is medicine is about well-being of the patient. We are not AI, so therefore we do not treat neutropenia. We do not treat low hemoglobin, but we treat a patient with neutropenia. And always remember, we are human being doctor. We are not AI doctor, and that's what the difference, right? Chilong mentioned something very important is about he's telling a lot of stories. Now, a lot of stories means what? A lot of story means that what happened in the past matters at the present, and then that will helps whatever we want in the future. So when we take history, we are not taking history of symptom of how many days, but you know the severity, and the more important Chilong also bring in about ACP is the right context. Yep. Now I will want to challenge the group is can we have a show of hand? How many of you, after listening to this talk, think that you can try to have this conversation? Can we have a show of hand? You think you would want to try to have this conversation? If you choose not to talk, I will agree, but share with us. Would you want to try to have this conversation? Okay. Question number 2. Oh, 7. Any more? 6. Only 6 want to try. Everyone. Okay, Asha, good. Now, second question. Oh, 9. Can we go higher? It's less than 10% today want to try. 11. Now, may I ask is, do you worry that if you want to try, it will take you a lot of time? Okay, we will stop question 1. Now we start with question 2. Do you think that having this conversation that Chilong is sharing, do you think it will waste a lot of your time? 6. The rest you think is all right, is relevant. How come kurangkan? No? Okay, good.
Because they don't think it's a waste of time, I hope.
All right, so Chilong, I would like to, okay, all right, very good. Yeah, Shasti, thank you, very good. So, it's very touched to see all of you really participate. So Chilong, what are the questions that you would like to ask today's participant? One question you want to find out. Okay, thank you, Oi, it's worth to try. Yes, that is why we are here today, right?
I mean, I would like to ask whether I guess on one hand, what would be the concern about having the conversations? Because in a way, for many of us, me included, when I first wanted to try and have these conversations, like I make all the silly mistakes and do silly things. Is it important to have? Because we work quite closely with our MOH counterparts as well, and I know they had spoken at many of the previous sessions for this month, whether there could be a more concerted effort on the part of the palliative care community, fraternity to your hospitals, and whether maybe systems can be established. Because if we fail also, we need to understand why we failed and what we need to do to make it better. It may not be us. Patients may not be receptive. I don't know. We just need to begin somewhere. Dr. Rashida, thank you so much. Yeah, thank you. That's a very good comment. Many not comfortable as beginners. Yeah, we were all beginners. Would it help to have workshops? Because, like I said, the QE team have had 2 workshops as far as I know in the last 2-3 months, which is, I think, quite hugely encouraging to us. But if you have some interest in your own hospital, maybe it's something that we could try and work with our colleagues in supporting, because it's something that we are passionate about, and yeah, for me, it kind of is. These are part of the nice things of palliative care, I would say.
Yes, Rauda, you also agree. Thank you very much. Now, so I would just like to do a short summary of, I think Chilong bring up a few very important points. Is remember, we are all here for the well-being of our patient. Yeah, listen to the story. Being a kind doctor means few things. Means wanting to listen, wanting to understand, listening to understand, not listening and then to find kind of a plan and to push forward our plan. Yeah. And being kind, also, mentioned about respecting patients' choice, understanding their values, what do they want? And Chilo also mentioned that, please, I think we should avoid asking you want CPR or not, because decision is about shared decision, shared responsibility. So give them appropriate information so that they can make decision in the right context. Yeah. I think lastly, I think Chilo also mentioned is a lot of time is not about what to say, but it's about asking, wanting to understand. Ya, macam kita cakap sibuk sikit, kepo sikit. You know, the wanting to understand and to have the connection with the patient. So I will open to the floor one more time. Any question? Yeah. So please try to do whatever we have discussed. And I guarantee you, you will only feel, not only that we ourselves feel better, but definitely you will make a patient feel much better, heal much better with your kindness. Yep. So, Chilong, anything you want to add?
No, thank you for the very succinct summary, and thank you very much everyone for attending. And I would just like to say Merry Christmas to all who are celebrating, and Happy New Year and holiday to those of you who are off.
Okay, so Dr. Narisha, we pass back to you. Shall we conclude today's session?
Sure. Thank you very much, Dr. Lam and Prof. Law, for this wonderful session on advanced care planning. And I hope after this, more of us focus on treating the patient with the disease rather than treating the disease alone. So do join us again for our next session, which would be in the month of January, the month of gastroenterology. And with that, we would conclude today's